Welcome back to the fourth section of our course, where we will tackle advanced procedural coding and the critical application of CPT modifiers. Now that you understand the basic structure of the Captain Manual, we need to explore how to code complex surgical scenarios and apply modifiers to tell the complete clinical story. This topic is incredibly important, because modifiers directly impact how much a physician is paid, and misusing him is a leading cause of insurance audits. I am excited to guide you through these advanced rules, because mastering modifiers is often the key to achieving a high score on your certification exam. Let us dive in and build your confidence with these challenging concepts. The first advanced concept you must master is the global surgical package. When a surgeon performs a procedure, the CPT code they bill does not just cover the physical time spent in the operating room. The surgical package actually includes all the standard preoperative care, the surgery itself, and the routine postoperative follow-up visits. Because these services are bundled together into one single payment, you cannot bill separately for a routine checkup that occurs during the patient's normal recovery period. Understanding what is included in this global package is essential for knowing when it is appropriate to use a modifier. The length of the global package depends entirely on whether the surgery is classified as major or minor. A major surgical procedure carries a 90-day global period, meaning the surgeon cannot bill for related follow-up visits for a full 3 months after the operation. Minor surgical procedures and endoscopies usually have a 0-day or 10-day global period, because the patient recovers much faster. The exam will test your ability to look at the date of a follow-up visit and determine if the patient is still locked inside the global period of their previous surgery. When a clinical situation falls outside the normal rules of the global package, you must use a CPT modifier. A modifier is a 2-character code appended to the end of a CPT or HCPCS code to provide additional information to the insurance company. Adding a modifier tells the payer that a service was performed exactly as described by the code, but some specific circumstance altered the situation. Modifiers explain things like whether a procedure was performed on the left or right side, if it took unusually long, or if multiple doctors were involved. Let us look at the modifiers used specifically during the global surgery period. Starting with Modifier 24. Modifier 24 is used when an evaluation and management visit is performed during a postoperative period, but the visit is completely unrelated to the original surgery. For example, if a patient had their appendix removed last week but comes into the clinic today complaining of a brand new ear infection, you would append Modifier 24 to the office visit code. This tells the insurance company to pay for the ear infection visit, because it has nothing to do with the recent appendix surgery. Modifier 25 is arguably the most heavily tested modifier on the entire exam. It is appended to an evaluation and management code to indicate that a significant and separately identifiable service was performed by the same physician on the same day as a minor procedure. For instance, if a patient comes in for a routine checkup and the doctor suddenly discovers a suspicious mole and removes it, you would add Modifier 25 to the checkup code. This proves that the doctor performed a full cognitive evaluation before deciding to perform the physical mole removal. Similar to Modifier 25, we have Modifier 57. which is known as the decision for surgery modifier. You will append Modifier 57 to an evaluation and management code. When that specific visit resulted in the initial decision to perform a major surgery with a 90-day global period. If an emergency room doctor evaluates a patient with severe trauma and decides they need emergency orthopedic surgery right now, Modifier 57 ensures the doctor gets paid for the initial trauma evaluation. Without this modifier, the insurance company would deny the evaluation as being bundled into the upcoming major surgery. Sometimes a patient experiences a complication from a surgery that requires them to go back into the operating room. If a patient returns to the operating room for an unplanned procedure related to a complication from the original surgery, you must append Modifier 78. This modifier indicates that the return trip is related to the first surgery and is not a brand new problem. It is important to note that using Modifier 78 will usually result in a reduced payment from the insurance company, because they are only paying for the intraoperative portion of the return trip. In contrast, Modifier 79 is used when a patient returns to the operating room during a global period for a completely unrelated procedure. Imagine a patient who recently had a hernia repair and is still in their global period, but suddenly breaks their arm and needs emergency surgery to fix the bone. The surgeon would bill the arm surgery with Modifier 79 to tell the payer that this new procedure has absolutely no relationship to the healing hernia. Using Modifier 79 successfully restarts a brand new global period specifically for the broken arm. Modifiers are also used to indicate anatomy, such as Modifier 50, which is used for bilateral procedures. A bilateral procedure is one that is performed on both sides of the body during the exact same operative session, like replacing both knee joints at the same time. However, you must read the Captain Code description very carefully before appending Modifier 50. If the official code description already includes the word bilateral, or specifies one or both sides, you must never use Modifier 50, because the bilateral nature is already built into the base code. When a surgeon performs multiple separate procedures on the same patient during the same surgical session, you will often use Modifier 51. Modifier 51 tells the insurance company that multiple procedures were performed, and the payer will automatically apply a multiple procedure payment reduction. The primary, most expensive surgery is paid at 100%, while the second and third procedures are usually paid at 50%. You should always sequence the most complex, highest valued code first on the claim without a modifier, and append Modifier 51 to the lesser valued secondary codes. Modifier 59 is known as the Distinct Procedural Service Modifier, and it is the most famous modifier in the coding world. You use Modifier 59 to indicate that a procedure was completely distinct and independent from other services performed on the same day. This modifier is an override switch that allows you to bypass bundling edits when a secondary procedure was performed on a different organ, at a different surgical site, or through a separate incision, because it overrides billing edits. Modifier 59 is heavily monitored by auditors to ensure it is not being used to fraudulently unbundle codes. Because Modifier 59 was historically abused by some clinics, Medicare introduced 4 highly specific X modifiers to provide clearer reasons for unbundling. These are modifiers XE for a separate encounter, XP for a separate practitioner, XS for a separate structure, and ZOO for an unusual non-overlapping service. When coding for Medicare patients, you should always use the specific X modifier if it fits the clinical situation instead of the generic modifier. 59. The exam will definitely test your ability to choose the correct X modifier based on the detailed circumstances of the surgical report. Anatomic modifiers are another incredibly useful tool for providing pinpoint accuracy on your medical claims. The HCPCS manual contains specific alphanumeric modifiers for individual fingers, toes, eyelids, and coronary arteries. For example, modifier F1 represents the left-hand second digit, while modifier TAR represents the left foot great toe. Using these specific anatomical modifiers is far better than simply using left or right modifiers, because it paints a crystal clear picture for the insurance examiner. If a doctor removes a cyst from a specific finger, you must use the exact finger modifier to get the claim approved. In major surgical cases, a primary surgeon often requires the help of another fully qualified doctor known as a surgical assistant. If another doctor simply helps retract tissue and suction blood during the surgery, they are acting as an assistant and should append modifier 80 to their surgical codes. However, if 2 specialized surgeons work together to perform distinct parts of the same massive operation, they are acting as co-surgeons, and both should append modifier 62. Knowing the difference between an assistant surgeon and a co-surgeon is critical for accurate reimbursement and exam success. To prevent fraudulent billing and improper unbundling, the federal government created the National Correct Coding Initiative known as NCCI. The NCCI is an automated editing system used by Medicare and Medicaid to ensure that certain codes are never paid together if they represent the exact same work. Understanding how these edits function is vital, because commercial insurances have also adopted these exact same rules. The exam will expect you to know how to navigate NCCI rules to determine if 2 procedures can be billed together or if one is considered a bundled component of the other. The NCCI system works by pairing codes together into a column 1 and column 2 format, known as procedure-to-procedure edits. The column 1 code is the comprehensive primary procedure, and the column 2 code is the smaller bundled procedure. If you try to bill both codes together, the insurance computer will automatically deny the column 2 code and only pay for the column 1 code. Your job as a coder is to look at the documentation and determine if the work described by the column 2 code was truly separate and distinct enough to justify bypassing the NCCI edit. To know if you are legally allowed to bypass an NCCI edit, you must check the modifier indicator assigned to that specific code pair. A modifier indicator of 0 means that there are absolutely no clinical circumstances where the 2 codes can be billed together, and you can never use a modifier to bypass the edit. A modifier indicator of 1 means that if the clinical documentation proves the 2 procedures were distinct, you are allowed to use a modifier like 59 to override the edit and get paid for both codes. This is exactly why detailed physician documentation is so important. When preparing for the exam, the best strategy for modifier questions is to read the operative report and physically map out every incision and action the surgeon took. If the surgeon performed 2 procedures through the exact same incision on the exact same organ, they are almost certainly bundled and cannot be separated with a modifier. If the surgeon closed the first incision, moved to a completely different part of the body, and started a new procedure, a modifier is likely appropriate. Always trust the physical evidence in the clinical note over your assumptions. Congratulations on finishing Section 4 and mastering these highly complex surgical and modifier concepts. You have done an outstanding job digesting this dense material, and you are now well equipped to handle the toughest procedural questions the exam can throw at you. I strongly encourage you to take the attached practice test right away, so you can practice applying these modifiers to real-world surgical scenarios. Working through practice questions immediately builds your active learning skills and solidifies your long-term retention. Keep up the fantastic effort. And I will see you in the next section where we will explore regulatory compliance and reimbursement methodologies.